Okay, thank you very much, Michael. Thank you very much, Jean-Louis, for your kind invitation. I'm very, very happy to be here with you. And my purpose today, this morning, will be to focus on the problem of preload measurements. What about cardiac filling pressures? What about end-diastolic volumes? What is preload? In fact, at the level of the myocardial fiber, preload is the length of the sarcomere just before the contraction. At the level of the whole heart, preload can be considered as the stress of the ventricle before its contraction. And for the routine assessment of preload, we have to estimate the sarcomere length or estimate the end-diastolic wall stress. How to do that? Either by measuring the left ventricular end-diastolic pressure or by measuring the left ventricular end-diastolic volume. For the first one, we may have the possibility to insert an intraventricular catheter and to measure directly the left ventricular end-diastolic pressure, but you know that it's not a routine method. So the method we can use at the bedside is to insert a pulmonary artery catheter and to measure the wedge pressure, pulmonary artery occlusion pressure. Remember that the wedge pressure is the pressure obtained after inflating the balloon of the pulmonary artery catheter. And when you inflate a balloon, you occlude all the vascular segments just downstream to the tip of the balloon, the tip of the catheter. So there is no flow, there is no resistance, there is only a pressure which is equal along the vascular segment until the blood flow, the location of blood flow resumes. Therefore, PAOP, in fact, reflects the pressure in a large pulmonary vein. So it should reflect the pressure in the left atrium and should reflect the left ventricular end-diastolic pressure. This is a very recent study published in Chest comparing the value of left ventricular end-diastolic pressure and wedge pressure in a lot of patients, more than 3,000 patients. In this example, patients were patients with pulmonary hypertension, but in the paper, there are also patients without pulmonary hypertension. And in both groups, with pulmonary and without pulmonary hypertension, there is a correlation between wedge pressure and left ventricular end-diastolic pressure, but you can see it is a weak correlation. For example, some patients may have 35 millimeters of mercury of left ventricular end-diastolic pressure and may have only 2 or 10 or 25 or 35 millimeters of mercury of wedge pressure. And conversely, they may have 25 millimeters of mercury of wedge pressure and 2 or 10 or 25 millimeters of mercury of left ventricular end-diastolic pressure. So there is a correlation, but it was not a nice correlation. And when we look at this Bland-Altman representation, you can observe that the limits of agreement was very large, and the percentage error, which is the ratio of two standard deviations divided by the mean of the reference value, is only 50%, which is not acceptable. So why? Why wedge pressure sometimes cannot reflect left ventricular end-diastolic pressure? So for that, we have to respect some very important points. First one is to obtain a valid tracing. For example, in a patient receiving mechanical ventilation, you may have this kind of tracing. This is a correct tracing with a very nice decay of the curve after inflating the balloon and a nice wedge pressure tracing. You may also you may be sure that you have a correct zero. It is very important to have a correct zero, of course, and to measure the wedge pressure at the appropriate moment of the respiratory cycle. You know that all pressures must be measured at the end of expiration in order to minimize the direct influence of intrathoracic pressure. For example, in a patient receiving mechanical ventilation and fully adapted to his ventilator, it is very easy to detect the end expiratory pressure, which is 3 in this example. In a patient with spontaneous breathing activity, it is also easy to measure the end expiratory value of wedge pressure, which is 12 in this example. But sometimes it is difficult, because sometimes it is difficult to correctly measure the end expiratory wedge pressure in patients with assist control ventilation, in patients who trigger the ventilator, etc. And now there is another problem with wedge pressure, with the problem of PEEP, PEEP or interesting PEEP. In fact, we have to remember that in case of high PEEP or high intrinsic PEEP, PAOP may reflect alveolar pressure rather than left ventricular end-diastolic pressure. Why? You remember this cartoon. You also remember that PAOP reflects the pressure in a large pulmonary vein, provided that there is no interruption of the static column between the tip of the pulmonary artery catheter and the location where blood flow resumes. But if alveolar pressure is very high because of high PEEP or high intrinsic PEEP, auto PEEP, sometimes the capillaries, which are vessels submitted to the direct influence of alveolar pressure, can be squeezed. And therefore, in this case, PAOP does not reflect PVP, but reflect alveolar pressure. And sometimes it could be difficult to well interpret the PAOP measurements. And it is very important to emphasize on the P-half over PVP ratio, because there are some conditions that increase P-half, alveolar pressure, which are high levels of PEEP or interesting PEEP, but also there are some conditions able to decrease pulmonary venous pressure, for example, volume depletion. And if you combine high PEEP and volume depletion, you may have an increase in the ratio of alveolar pressure over pulmonary venous pressure. And in this case, there is high risk of misinterpretation of wedge pressure. So there is a possibility to solve this problem. Years ago, we proposed a solution. We assume that if PAOP well reflects pulmonary venous pressure, PAOP and diastolic pulmonary artery pressure must sense changes in airway pressure by a similar magnitude, because pulmonary arteries and pulmonary veins are submitted to the same intrathoracic pressure in the thorax. So we should have this kind of tracing with similar magnitude of change in PAOP and change in PAP, in diastolic PAP. But if PAOP reflects alveolar pressure rather than pulmonary venous pressure, then PAOP must sense changes in airway pressure by a greater magnitude than diastolic pressure. And you should have this kind of tracing with high value of delta PAOP in comparison with delta PAP. In this case, PAOP should reflect alveolar pressure. And this paper, we demonstrated that, and demonstrated that when we have a delta PAOP over delta PAP ratio above 1.5, this can identify misleading measurements of PAOP during a PEEP ventilation. There is another problem with PEEP ventilation, which is that even if PAOP reflects left ventricular end-diastolic pressure, it can poorly reflect left ventricular filling pressure because of the problem of high extramural pressure, as mentioned by Daniel De Backer just before. And expiratory PAOP overestimates left ventricular filling pressure in case of high PEEP or high auto PEEP, and it is better estimated by transmural PAOP. And transmural pressure is the difference between end expiratory pressure minus transmitted PEEP. So the question is how to estimate the transmural PAOP and or the transmitted value of PEEP. There are two different possibilities. The first one was described by Michael Pinsky. This is Pinsky's method. And Michael proposed to estimate transmural PAOP after disconnection of the patient from the ventilator, and he measured the nadir PAOP value just after disconnection, and he compared this value to the transmural left atrial pressure, because he studied patients during cardiac and after cardiac surgery and measured left atrial pressure directly and pericardial pressure, and he demonstrated that nadir PAOP well reflects transmural left atrial pressure. So it is a possibility. But in fact, this in patients with dynamic pulmonary hyperinflation, the airway disconnection method may suffer from limitations because of the slow rate of alveolar untying, which will not allow the fall of PAOP being maximal immediately after ventilator disconnection, and the increase in venous return also related to ventilator disconnection may occur before the decline of PAOP is completed. So this is an example in a patient with dynamic pulmonary hyperinflation with no clear nadir PAOP. By contrast, we have a very clear nadir PAOP in patients without dynamic pulmonary hyperinflation. So the next proposal was to estimate transmitted PEEP, and as mentioned by Daniel De Backer, it is possible to make the hypothesis that the changes in PAOP during a respiratory cycle are secondary to changes in alveolar pressure, and their magnitude would depend on the degree of transmission of alveolar pressure to PAOP. Thus, transmitted PEEP would be the product of PEEP by the ratio of delta PAOP over delta alveolar pressure. This is an index of transmission. And for example, in these patients, we can measure a delta alveolar pressure of 8, plateau pressure is 19, and the total PEEP is 11, and the delta PAOP of 5. And we can compute the ratio of the two values, and 60% of transmission. And if we if we multiply 60% by total PEEP, and we subtract this value from 14, which is the end expiratory pressure, we can obtain 7 meters of mercury. The true transmural pressure is 7 meters of mercury. Why? We measure 14 meters of mercury if we do not take into account this calculation. So besides pressure, we have also the possibility to measure volumes, and how to measure volume either by echocardiography or transpulmonary thermodilution. By echocardiography, we can measure the left ventricular and diastolic volume. We can also measure left ventricular and diastolic area. And in this very nice study, where patients were submitted to progressive hemorrhage and blood depletion, the authors demonstrated that the end-diastolic area was very sensitive to changes in blood volume, while stroke volume did not change at this moment. So it is a very sensitive measure of preload. But there are some limitations of echocardiographic measures of left ventricular preload. First, the problem of patient's echogenicity. Second, it needs a skilled operator. You should be a skilled operator. It is an operator-dependent method, you know. There are some geometric assumptions, and sometimes these assumptions are invalid in terms of measurements of left ventricular and diastolic volume, for example. And there are some potential errors in measurements, for example, for the length of the ventricle. And of course, continuous monitoring is not possible. And regarding transpulmonary thermodilution, you know that it is possible to obtain this parameter after injecting a cold bolus into the superior vena cava, and you can obtain, using the area of the thermodilution curve and the mean transit time, you can obtain the intrathoracic thermal volume. You can also obtain, using the Dowd slope time, the pulmonary thermal volume, and the computer is able to make the difference between the two volumes and to finally provide the measurements of global and diastolic volume, which is the volume of the maximal volume of the 4 cardiac chambers. And global and diastolic volume is assumed to be a marker of preload. We tried to check that in a clinical study with Frédéric Micha in the past, and we gave fluid to patients, and we observed increasing cardiac output and increasing global and diastolic volume in patients who receive fluid. And we also gave dobutamine to patients, and we did not observe any increase in global and diastolic volume, while we observe increase in cardiac output. So global and diastolic volume behaves as a marker of preload. And interestingly, responders to fluid had a lower baseline global and diastolic volume index than non-responders. And when we look at the rate of positive response to fluid, we observe that the rate of positive response to fluid increased when the global and diastolic volume decreased. So this parameter well behaves as a marker of preload. But there are a very important limitation of global and diastolic volume as a measure of preload. It is that global and diastolic volume could overestimate left ventricular preload in case of dilated right ventricle, because, in fact, global and diastolic volume, by definition, takes into account the dimension of the right ventricle. So, which is best between pressures and volumes? You know the relationship between transmural pressure and volume. For patients with a normal left ventricular compliance, for example, you may have 100 for volume and 10 meters of mercury for pressure. But in case of reduced left ventricular compliance, for the same 100, you may have 20 meters of mercury of pressure. And conversely, you may have 10 for 100 and 10 for 50 meters of mercury in case of a reduced left compliance ventricle. So it is linked, but one parameter does not mean the other parameter. And this is well demonstrated in this study, the O study by Raper and Teboul. They found no correlation between wedge pressure and left ventricular and diastolic volume measured by isotopes. And for example, a patient with 50 of volume, patients may have 5, 10, or even 35 meters of mercury of wedge pressure. And conversely, for a value of 10 meters of mercury of wedge pressure, you may have 50 or other values of volumes. And in this very nice study by Kumar and co-authors, the investigators gave fluid to normal subjects, and they measure wedge pressure, CVP, volume, etc. They did not find a very good correlation between wedge pressure on the x-axis and stroke volume index on the y-axis. They did not find any correlation between the changes in wedge pressure and the changes in volumes, in stroke volumes. But they found a good correlation between left ventricular and diastolic volume index measured by isotopes on the x-axis and stroke volume index measured on the y-axis. They also observe a very nice correlation between the changes in both parameters with isotopes, but also with echocardiographic measurements. Yes, one. Okay. And in this other study, Goodyear and co-workers also did not find correlation between delta stroke volume index and delta wedge pressure, and no correlation between delta CVP and delta stroke volume index, but a nice correlation between delta global and diastolic volume index and stroke volume index. So end-diastolic volumes seems to be more appropriate than cardiac filling pressure for assessing preload. However, we have to remember that left ventricular filling pressures and not volumes can provide indication on pressure existing in the upstream vessels, for example, lung filtration pressure, and this is very important for assessing cardiogenic preload, follow-up after treatment, etc. And also, it is a safety limit parameter in case of fluid therapy. We have also to remember that assessing preload is not assessing preload responsiveness, and this, you know, this kind of figure, and with a family of curves, framing of Frank-Starling curve between the normal heart and a filling heart, and a given value of preload cannot indicate preload reserve in this kind of patients. And we also, in this study, we also demonstrated that filling pressures were not appropriate to predict the hemodynamic response to volume challenge. And this was also found by this meta-analysis of Marwick and co-workers. And also, volumes are not appropriate. In this study, we measured left ventricular endocytic area before fluid infusion in responders and non-responders to fluid. We found no correlation, no difference between responders and non-responders. And also in this study, left ventricular endocytic area did not predict fluid responsiveness. So my conclusion is that end-diastolic volumes are probably more appropriate than filling pressures for assessing preload. However, assessing preload is not assessing preload responsiveness, and left ventricular filling pressures can provide indication on pressures existing in the upstream vessels, for example, lung filtration pressure. Thank you very much for your attention.